If you, for example, compare the ranibizumab arms in Rainbow to the ranibizumab arms in the CAROB trial, we saw much higher success rates in the CAROB trial compared to Rainbow, because the definition of the endpoint was not as strict as it was in Rainbow. On top of that, maybe a secondary factor is also that we have a global trial in Rainbow. So we have a combination of very different settings around the world with many factors that can affect success rates and success outcomes. That might have had a minor impact on the success rates, but I think the first factor, that combined endpoint, is really an important one.
Yes, could I just add to that? The key thing that differentiates Rainbow from a lot of the other studies is that this is a study where we are interested in the child's vision as the child develops, not just whether the retinopathy has stopped its progression and regressed. And therefore, that's why we made it very much more difficult for us to do that. And all the children in Rainbow are going to be followed up through 5 years.
Yeah, I think that is a very important point too that you bring up, Neil. We have to make sure we have these long-term follow-ups in all ROP trials, and not only trials but also outside of the trials, because there's simply no way of saying anything about functional outcomes before at least 3 years, better 5 years after treatment. Now here's a very practical question regarding the treatment. Do you prefer to give the anti-VEGF treatment bedside or in the operating theatre? Neil, how is it done in the UK at your hospital?
It's actually done in theatre usually, but that's because it's easier to do that there. There are some centres in the UK where it might be done in a room off the neonatal unit if they have a suitable room to do it in.
Mm-hmm. How is it in Mexico, Maria?
In Mexico, we do it in the bedside with only topical anesthesia.
Mm-hmm.
And for us, has been working very fine like that. Just taking a good precaution of using iodine before the injection and taking all the hygienic measurements to do the injection. But we do it bedside.
We do it in the NICU as well. I think it's really a decision that has to be made locally, depending on the infrastructure at each individual hospital. We decided to do it in the NICU in order to not transport the infant from one place to another place, even if it's in the same hospital. I think both is correct. There's no right or wrong answer here. You have to obviously adhere to all the hygienic standards, but it can be done both ways. I'm reading another interesting question here. When do you retreat if there's no response to treatment after anti-VEGF? I think this is also a challenging one, Maria. How do you decide that first of all, how do you decide there's no response to treatment, and what do you do if you see that?
When I decided not response to treatment is that in the following 48 hours, the baby is the same or worse than how it was before the injection. The first thing is to make sure it is ROP, because it sometimes could coexist another disease like a CMV, like a virus, for example, or other hemorrhagic vasculopathies in a baby. The second is that one of the most frequent failures in treatment is due to an empty needle when we do the injection. The dosage is so small that sometimes the needle is empty and you're basically not injecting anything. So you have to make sure that the needle is full of medication.
Yeah. And
that's probably one of the main causes of non-respondent patients. That one, it is not ROP, that the diagnosis should be readdressed, and the second is in the technique, that the needle is empty.
Yeah.
That's for failure to treatment. And then retreatment is a different thing.
Yeah, I think that's really a very important point to take into account, the fact that it is possible that you might not have injected anything at all. We inject a tiny volume from a relatively large syringe. And it has been a bigger problem than it is nowadays, because now we have the low volume syringe that has been developed for ROP infants. That should make life easier. But injecting 10 microliters of your medication from a 1 ml syringe is a tricky task, and it's not always easy to be sure you have really injected the full amount of your drug into the eye and not lost it somewhere on the way. But this should be easier with the low volume syringe now. Neil, here's another question that affects both the neonatologist and the retina specialist or pediatric ophthalmologist. When and how are parents being informed about the diagnosis of ROP? How do you do it? Do you wait until it's likely they need treatment, or do you educate everybody from the start about the ROP risk and all the implications?
I think it's really critical that we start educating them early. One of the challenges with retinopathy is all the neonatal illnesses are just getting better, and the baby's just beginning to start thriving, and suddenly someone comes along and says, he needs an operation on his eye. And it's really important that the parents are prepared for this. And so we, right from the very beginning, as part of our introduction to the unit, point out that on a particular day in the week, the ophthalmologist will visit, and when the time comes, he's going to visit this particular family's baby, and we tell them why he's going to do it and what the important things are. And this is really important as part of the education of parents, in that they can be very helpful to us in regulating the supply of oxygen when it's variable and the child is having desaturations, etc. If they understand why they're doing it, they're much more likely to do it with much more care and attention. So I think it's important. The EFCNI have developed standards for neonatal services, and I would recommend all of you to have a look at these standards, because there is one for screening for retinopathy in that, and it talks about early education of parents.
Here's another interesting question coming from India. We see a lot of AP-ROP zone 1 disease, and the question is what our views are on combination therapy for these eyes. So really aggressive posterior ROP in zone 1, do we inject or do we laser or do we give a combination? Maria, what's your thought on this?
Well, in Mexico now we're running a protocol in these babies, and what we are doing is we are doing early vitrectomy. If we do identify the AP-ROP as a real AP-ROP and the vitreous is involved, the outcome is better if we do a vitrectomy. We usually use anti-VEGF 1 day prior to surgery, or sometimes in the morning we do the injection and we do the surgery at the afternoon. But if the vitreous is involved, we have good outcomes with vitrectomy. In other patients where the vitreous is not involved, we do anti-angiogenic therapy, and then we have a very, very close follow-up, and we do laser if necessary in these patients.
So in Germany, the first-line treatment for AP-ROP eyes would be anti-VEGF, because I think the main advantage here is that you have an immediate effect. If you only laser these eyes, you have a delay of your treatment effect simply by the fact that laser does not get rid of the VEGF that is already there. It just stops the production of new VEGF. So I would always say that the first thing to do when you see AP-ROP is to inject anti-VEGF, even if it's only to gain some time. And then I do agree, you often have eyes that don't respond to a degree that you had wished for in the first place in these aggressive eyes, and you have to be able to give a second line of treatment. And that second line can either be a re-injection, it can also be a laser therapy, or in severe cases you might have to do surgery. We tend to try and avoid surgery. That's a bit different from Maria, what you just described. We try and avoid vitrectomies. We try and gain as much time as possible and as much viable retinal tissue as possible by injecting anti-VEGF and maybe re-injecting it a second or a third time. If you see a response to treatment and you see the physiological vasculature growing out into the periphery, and then you see a reactivation